So, good day, everyone. Welcome to the IAA YouTube channel. My name is Manon Raap. I'm from the Netherlands and I'm part of the IAA committee. Today, I have the opportunity to interview Dr. Luca Deabate about his surgical practice regarding the treatment of arthrofibrosis. He is an orthopedic surgeon specialized in the knee joint in different fields of practice, mainly sports medicine, degenerative joint disease, and knee stiffness. He's a head of knee surgery in Lugano, Switzerland, and he's the coordinator of the surgical team that works with the European Arthrofibrosis Center in Lugano, where he closely works with a multidisciplinary team of specialized physical therapists and pain specialists to provide the best possible care for arthrofibrosis patients. Luca, great to have you here.
Thank you very much, hi Manon.
Can you tell us about the importance of the treatment of knee arthrofibrosis as part of your surgical practice?
Yes, so the arthrofibrosis of the knee has started to become an important part of my practice, of my weekly surgical practice. Thanks most of all to Sebastiano for that, because he involved me in the past, making me realize that there was a lack of knowledge and skills in treating this pathology, which has started to become a major issue right now. So the numbers of knee surgery are growing, and so that's the complications. So that's why I'm here right now.
Excellent. Yeah, thank you so much. So for the remainder of this interview, we'll have three parts, split up by the source of the questions. So we'll start with questions from an Australian orthopedic surgeon, followed by questions raised by the IAA committee, and finally we'll have some time for questions from patients.
Go for it.
So the first question from the orthopedic surgeon is, what are the most important aspects of knee replacement technique to consider when trying to prevent arthrofibrosis?
Preventing arthrofibrosis totally is almost impossible. What I'm paying attention right now are actually three things. And so the first of all, the balancing of the total knee arthroplasty is very important. So I try to avoid the stiffness. So I try to find a good balance between the stability of the joint replacement and the loosening of the soft tissue. So it's very important to not making it mechanically stiff in order to give the knee some space for the rehabilitation. The second thing is the soft tissue release. So I try to keep it minimal in order to prevent big changes in the biomechanic of the knee, of the replacement. And third, and I think most important, the hemostasis. So I pay really great attention to the hemostasis procedures.
Okay, thank you. The next question would be, if you had to scope and manipulate a knee replacement and clear tissue for arthrofibrosis post-knee replacement, do you use any special techniques?
Normally, in most of the cases, I will do it arthroscopically. And in this, I don't use special techniques, but just I pay attention to a few details. So I'm not using tourniquet at all. I don't put too much pressure in the water pump for the arthroscopy. And I'm absolutely not using shaver, which is painful from my side because it makes the procedure longer, but it avoids bleeding. And I use radiofrequency or the vapor, so something that burns the tissue when I need to free and to cut it out, something. And then at the end of the procedure, I always do 10 minutes hemostasis in the soft tissue to avoid bleeding afterwards. Yeah,
Okay.
these are.
Yeah. Excellent. And do you inject the knee with anything at the time of surgery?
No. I was considering using some kind of vasoconstrictor in the water that we use for the arthroscopy procedure, but no, I'm not using nothing and I don't inject nothing.
Okay, yeah. You already mentioned that you don't use tourniquets during the arthrolysis surgery. And how about using a tourniquet in TKR to help with cement preparation and in the implant stage?
So I don't use tourniquet during TKAs for most of the time. So during the preparation, the cuts and whatever, and the trial procedure, I'm not using a tourniquet. I just use the tourniquet for the cement, and I try to keep it as low and as low as I can, and try to stay under the 20 minutes time. So it allows the cementation process to complete, and that's it. And then I release it, I do an hemostasis, and then I close.
And have you used microembolization to control neovascularization?
Is a very good question. Not yet.
Okay.
I'm studying it and I'm building another part of the team, which is the radiologist, to start doing this kind of procedure. And I'm now hoping to start in arthrofibrosis patient in the next 2 months.
Okay.
It is a promising technique.
Okay. Yeah. Would be interesting to hear the results.
Yeah.
Yeah. And so this surgeon asking these questions, he sees a lot of patients that would like to know what is in their power to modify the risk for developing arthrofibrosis. Do you have any tips that he can pass on to those patients?
So I think it's important for the patient to raise the awareness of this kind of problem and complication. So we need to educate the patient in order for them to be able to recognize the onset. So this is the timing is of the essence in this case. So I spend a little bit of time before planning the surgery, the TKA surgery or whatever, speaking about this kind of complication, because if the patient knows that can call someone when he recognizes the onset of a possible arthrofibrosis, then I think this is the most crucial point. If we can start early with the treatment, with the physio, with maybe non-steroidal medication or whatever, it is, I think, the key part of the process.
Yeah. Okay. Yeah. And what message would you like to share with other surgeons who would like to understand more about this topic?
Good luck.
Yeah.
I mean, there is something in literature that can help build some knowledge in surgeon. There are no clear guidelines, but as long as even the surgeons or the physio are interested in the matter, then this is already something very important. But technically speaking, to give some tips to the surgeon, I think in a total knee, if you want to avoid or try to keep it minimal, the risk of arthrofibrosis, 2 key points: the balance of the total knee replacement. So try to not make it too stiff at the beginning, and then control the bleeding.
Control the bleeding. Okay, yeah.
And then a key role afterwards, it's the physiotherapy has to be on point, knowing the problem and knowing the techniques.
Excellent. Yeah. Then we'll move on to the second part with the questions from the IAA committee. So the earlier questions were largely about TKAs. So now for general surgeries, when you are meeting a patient for primary surgery, are there any red flags that may lead you to believe that this patient is at risk of developing post-op arthrofibrosis?
Unfortunately, this is a good question, and there is a lot of debate around that. Psychological traits or something. I don't have any clear red flag. What for me is, I think the most important thing is the commitment of the patient. So, I mean, what I always said is surgery is 50% of the success. The other 50 is rehabilitation and patient. So the willingness to heal is, I think, one of the key parts. Then sometimes it happens even in the most committed patient, and you can do nothing really to help them or to avoid the complication. So I would just pay more attention in patients that are more, pass me the word, lazy. And so I'm a little bit stricter with these kind of patients, but I don't have any clear red flag to share.
Yeah. Okay. And what is your overall surgical approach to knee arthrofibrosis? You already mentioned a couple of things. Maybe that was specific to TKA arthrofibrosis, but in general?
In general, I try to avoid to operate on this patient. And I'm explaining this.
Okay.
What I do normally in an arthrofibrotic patient is really try to exploit all the benefits of the physical therapy before considering going in the OR, before even thinking about surgery. And the other thing is only to do surgery in very calm knees, so non-reactive knees, trying to avoid the rebound of the result, because I can achieve a good mobilization, surgically speaking, but then if the knee is still reactive, it's more likely to bounce back to stiffness, pain. And so really, I think that the most crucial point in deciding for surgery is timing. So decide the right timing to go in the OR, and then, of course, we're going to speak about other key points that are more technical.
Okay. Yeah. All right. So you briefly mentioned already the use of tourniquets during routine knee surgery. You actually already mentioned that you never use tourniquets except for the cement stage. We could continue to the next question.
Concerning the TKA, this is my behavior normally. For the arthroscopic procedures, so ACL reconstruction or meniscal procedure and whatever, it depends. I try not to use it, but to twitch a little bit the water pump values in order to have a good vision. Okay. And so not using the tourniquet. I think on a basic principle, you can use the tourniquet as soon as the procedure is fast. And after the use of tourniquet, what I always do is I take it out prior to closing, and I pay attention to the hemostasis as my last step in the surgery.
Okay, yeah. Excellent. Thank you. Yeah. How about post-operative pain control? Is that an important part of your plan?
It is a crucial part of the plan. Yeah, because actually we have a very good pain service here. So the anesthesiologist that do the procedure in the OR actually follows for the next 48 hours the patient. So whenever the pain management is not good, we call them that are specialists. And so yes, it is very important that the patient has pain under control in the next 48 hours in order to start the mobilization and not to have any other problem. Yeah.
Okay. Yeah. And what is your philosophy on how to approach knee arthrofibrosis in terms of physiotherapy, pain management, but also psychology, care of complex patients and perhaps also his or her caregivers?
I had one of my best teachable moments when I was in Geneva by the chief of the university, the orthopedic department, that said saliva is the most important thing. And this was meaning you have to listen to the problem, believe the patient, and the most important part and most difficult part, explain what is going on and what is the reason of this kind of patient that normally have problem for years. They have already had maybe a lot of surgeries. They are in pain, and so the listen to the problems and explain what is going on, and also your thought and your reflection about the specific case. So this normally helps a lot the patient to understand and to bear with the problem.
Yeah. Makes a lot of sense. Yeah. Some unfortunate patients also develop patella baja.
Yeah.
In these cases, what are the pros and cons of TTT surgery versus lengthening of the patellar tendon?
So the patella baja, it is a major problem. We have a shortening of a tendon, and so from a logical point of view, from a logical starting point, it would make more sense to lengthen the tendon instead of touching the bone. Actually, it's not my philosophy because I'm scared of the reaction of soft tissue. So I try to avoid lengthening the tendon because I'm afraid that I can cause a higher retraction or biological problems, so a healing problem. And I don't want to deal with the unhealed or a vital tendon instead of dealing with bone problems. So in my opinion, the pros of a TTT procedure, it's that it gives me a higher percentage of healing and less complications. And even if it is a retracted tendon, is still an untouched tendon, and it is I think one of the most important tendon in the body, and I don't want to have problem with that.
Yeah.
So this is my opinion concerning this question. So not avoid touching the soft tissues.
Yeah. Okay. Yeah. Thank you. Yeah, makes a lot of sense. And could you perhaps please explain sagittal partial patellectomy, including its indications and the goals of this procedure?
So, yes, do you have 2 hours? No, I try to make it quick. Yeah.
For our next interview, our next video.
Okay, maybe we can explain it with pictures and in a more complete way in another interview, maybe.
Yeah. Okay.
Because it's something relatively easy, but difficult to understand. When I explain to patients, I always use pictures and X-rays to make it clearer. What I do with the partial patellectomy is to normally when there is a hyperpression or arthrosis or other problems that constrict the knee, and especially the extensor mechanism, the patella react by putting some more bone, especially on the lateral part.
Okay.
So what we can find is a bigger patella, and we need to cut it out a little part. Normally it's the lateral part. It less than 1/4 of it, less than 1/4, but the excess of the patella, in order to make more space for the patella to move, and to make a more normal path during the flexion extension movement. And in the same time, since we are operating on the lateral side, doing a lateral liberation of this part of the retinaculum, which is, I think, the main part when we have retraction, the more stiff part. So the two effects are to give the patella more room, to give the knee more room, excise the excess of the patella that sometimes we can find, and doing a lateral liberation to have a more free patellar movement.
Okay, yeah, great, thank you.
Yeah.
So is it actually possible? So yeah, the Hoffa's fat pad is a very sensitive organ. Is it possible to do ACL reconstruction or a TKA without cutting the Hoffa's fat pad?
ACL reconstruction, is it possible? But we need to pass through it in order to access the joint. Then the Hoffa fat pad, actually, it's this structure that helps prevent mechanical stress on the knee joint. So it's something that is really sensible. So we need to pass through it. We can be minimal in the resection, speaking in ACL reconstruction, but it's something we need to get some room to operate. What is the normal behavior for a surgery is to do a proper cleaning, a big cleaning, because we want to be comfortable with the vision. We can be minimal in this. In the total knee, so in the open surgeries, again, we need to resect a little bit of it in order to access the joint and to see correctly what we're doing. But we can of course doing a partial resection and not a total resection. We have to do a partial resection in the total. We can try to be minimal in this, but sometimes it's difficult.
Okay, yeah, I see. All right. So when you're talking to medical students and residents, what is the one message or piece of advice that you would like to give them about arthrofibrosis?
That it is painful to treat. This is my best. No, what I normally say to assistants or residents that are helping me with these patients, it is trust the patient. You cannot imagine what they've been through, and normally it's really a painful story. And so this is the listen and believe what they are doing, what they are saying, because they are not. I think they are not inventing stuff. And then the other message I try normally to pass through all my colleagues or students are that this is a biological problem, and for now, for the most of parts, we only have mechanical answers. So it is something very difficult to treat, and so it's a long way, it's a long journey that you have to do with the patients.
All right, then we'll arrive at the last part of this interview, the questions from the patients. So for the first question, what is the rate of success of treating patella baja? And if it doesn't get better, is it possible to get worse?
Okay, tough question. You cannot put numbers on success rates because every case is different. So it really the success rate, it really depends on the case you're treating. What I can say is that even in the toughest case, normally we see even a small improvement. So normally we see a kind of improvement, although it's very, very, very difficult to put numbers on that. What is also important to understand is taken at the right time with the right procedure and the right rehab afterwards, and also maybe pain treatments. It's rare, very rare to see worse result. So to see a patient in a worse situation than before the surgery. Achieve 100% success in patella baja is almost impossible as well. So it really depends on the case.
All right. Well, this patient wants to know the current best practices and most successful techniques, including medication around the surgery and recovery.
I mean, it is, let's say in French, say à la carte. It's a la carte treatment.
Yeah.
So we already talked to what is the best practices, technically speaking. What is very important is to have a multidisciplinary team. So the patient is being taken in charge by a lot of different figures that can do their best in their field to have a good pathway. So I think this is the best thing. So it's the surgeon is important, but I would say it's not the most important part. The physio as well, the pain specialist as well, they play also the key roles in that. And if we can find this kind of team, I would say this is the best that we can offer to a patient right now. I think there is no thing such as a checklist to take.
Yeah.
I mean, it's difficult to.
Yeah. Really.
Also, every case is different as well.
Yeah. Very specific on the case. Yeah.
Yeah.
And so, if you're treating an arthrofibrosis patient, what is the likelihood and degree of improvements in generally speaking, associated in terms of pain and function?
Compared to an untreated arthrofibrosis, it's very likely to have an improvement, and we need to differentiate between a complete and total healing of the thing, which, as I said before, for the patella baja, it's almost impossible. Something we have to aim for, but it's almost impossible to have a normal knee after an arthrofibrosis onset. But it is very, very frequent and likely in any case to have an improvement in mobility, in stiffness, and pain control if the patient is taken in charge by a multidisciplinary team. Yes.
Yeah.
Okay.
Well, that sounds promising, at least. Yeah. Have you heard, or are there any promising developments in the pipeline for those who are trying to hold out for something perhaps even more successful?
Hopefully. As we talked about before, I think microembolization is something very interesting that we can explore in the very next future. So it's something I'm really looking for to see, and it is already tried in frozen shoulders.
Okay.
And it has shown good results. So hopefully also in the knee can be something that we can use. What we are looking into right now is the treatment. We know the cardiologists they have been treating pericardial fibrosis with colchicine for a few times with good results. And pericardial fibrosis, it's sort of fibrosis of another part of the body. And so we are looking into it to make the colchicine treatment for after the surgery something part of the algorithm of the treatment. And then what we are hoping is to find someone committed enough to understand also the cytokine panels that we sometimes run in the patients, and to use that informations in order to give treatments to the patient adapted on the case. And this is very, very, very difficult to do, and we need some rheumatologist or some specialist that can maybe give us a hand in doing that. These are, I think, the things that right now are in the pipeline. The other promising developments are maybe in physiotherapists. We are spreading awareness, and so having more and more physio guys involved in that, and knowing the complication and the treatment will help us to treat the patient better.
Okay, yeah, excellent. Yeah. So another aspect of arthrofibrosis is extension deficits. Do you have experience with surgical treatment of extension deficits?
Yeah, it's really tricky.
Really
Sometimes the extension deficit comes from an anterior interval problem. So the fibrosis in the off of head pad, maybe it's impinging, and that is locking the knee, and so blocking the extension. Sometimes is a posterior problem. So I think the tricky part is understanding where it comes from, the deficit, and then address it in a proper way. The posterior liberation is something very difficult to, not surgically speaking, because we can do that very well, but then for the physio point of view, for the rehab point of view, it changed everything. And so you need to work in really close correlation or relation with the physio, because when you do something, then the answer in the rehab has to be something else. And so, yes, I have experience. Normally with an anterior liberation, you can achieve enough to go to give room for the physio to work on it and to achieve a complete extension. Sometimes you cannot do that, and so you have to go to posterior liberation. But the physio has to be ready to treat them in a different way.
Yeah. All right. Yeah, thank you. So, is there any treatment to reduce pain from arthrofibrosis in these that have had it already long term, maybe 5 years or more?
Yes, again, each case is different. What I do when I see a patient that has a long-term arthrofibrosis, it's that I try to put the pain specialist on the first line, because he has the, I think, most effective weapons to help the patient in this case. So yes, probably almost always we can find a way to make it better. But I think the key figure in this specific situation is the pain specialist, rather than the surgeon.
Okay, yeah. All right. So to close off this interview, our last question already, could you tell us a bit more about your interdisciplinary team at the European Knee Arthrofibrosis Center in Lugano, Switzerland?
Yes, of course. So actually, as I mentioned, I work with very skilled physiotherapists, and they play the major role, more than surgeon. The major role. So the physio are the first in line to help the patient, to listen to them, to try to motivate them. So this is, I think, it's the key part. Then I have one of my assistants who is skilled in the surgery and on the indication for surgery, and he helps me. It's called Marco. He helps me also in the OR, because this procedure can be not technically difficult, but physically demanding. So it is important to have someone that can help you, and maybe giving you 5 minutes of rest during the procedure. That sometimes there's liberations can take as long as 4 hours.
Oh, wow.
And so you need a good help. You need a good
Yeah.
hand to help you sometimes. Then we have Dr. Tasciotti, which is a very, very good pain specialist. And it is skilled in knees, especially. So we developed a relationship because he was interested in the painful knees and arthrofibrotic knees, and so that we built on that. Then I sometimes, because she's very busy, use a rheumatologist to help me maybe differentiate other pathologies and give me hints and treatments for that. And then last but not least, my secretary. Because arthrofibrosis patients are, of course, they have a long history, and so they are demanding. So you need something empathic enough to listen to them and to maybe and tweak the agendas to make space for them, and so I think also this is a key part of the team.
Yeah.
That's it. It's a very small
Great.
team.
Yeah.
Perfect.
No. Wonderful. Yeah. Thank you so much.
You're welcome.
Yeah. So thank you for all this very valuable and helpful information.
Thank you for the opportunity
Yeah.
of speaking of this kind of a problem.
Yeah, excellent. Yeah, and for the viewers at home, if you have any questions, let us know in the comments or go to our website at arthrofibrosis.info.